Good afternoon, and welcome to Developing a Multifaceted Patient Matching Strategy to Fuel Interoperability, a Health System CIO Media Inc. production sponsored by MediQuant. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of Health System CIO, and I will be your moderator today. We're looking forward to your participation. You can send in questions or comments at any time in the Q&A box, and we'll take those later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35-40 minutes with our main panel discussion featuring Tony Ambrosi, SVP, Chief Information and Digital Officer with Baptist Health, South Florida; Audrius Polakaitis, CIO and AVP of Health Information Technology with the University of Illinois Hospital and Health Sciences System; and Kel Pultz, Chief Clinical Officer with MediQuant. So let's jump right in. Tony, let's start with you. Can you give us an overview of your organization and your role?
Of course. First of all, thank you for having me here. So I'm the Chief Digital Information Officer. As you said, that's a mouthful. I was brought into Baptist about 2 years ago to drive the digital transformation, first and foremost, for the system. Baptist has always, by the way, Baptist South Florida. Health South Florida is a 12 hospital system in South Florida, 26,000 employees, serving a lot of folks, and very well loved in the community. And it has enjoyed for many, many, many years a very forward-looking leadership at the executive steering committee and the board that looked at the things around technology and digital experiences as something very important for the future of Baptist, in addition to continuing the type of quality care and compassionate care and welcoming care that we talked about just before this, that we have been known for.
Very good, Tony. Thank you. Audrius?
Good morning, good afternoon to all. Again, thanks also for this opportunity. So my name is Audrius Polakaitis, Chief Information Officer at the University of Illinois Hospital and Health Sciences System, also going with the marketing name of UI Health, given that the other name is a mouthful. Fundamentally, we are a university academic health system, classic university health system in that respect. We are a patient care delivery organization surrounded by 7 health science colleges. So really 3 missions that we focus on, those being research, teaching, and patient care. And of course, those missions tend to blend together with each other. The vast majority of my time is spent in the patient care part of the organization, delivering all of the infrastructure, systems, services that are used by our clinicians, caregivers, and support staff as we serve our patients and their families. As an organization, we have a large focus on community engagement, on disparities, essentially, and dealing with this question of health equity. Thanks.
Very good, Audrius. Thank you. Kel?
Hi, Kel Pultz from MediQuant. So I want to thank everyone for joining today for the webinar to start with. I'm the Chief Clinical Officer at MediQuant and the Vice President of Government Strategy. I oversee our client services group, and also I'm the chair of our Health Regulatory Committee at MediQuant. So MediQuant itself has been in business since 1999, leading the active archive space, specifically around healthcare activities, so HR payroll, clinical, ERP. We kind of, anything you've got in your healthcare system, we put in an active archive. And I think the difference here is the word active. So you need to be able to do everything in our system, basically, that you were doing your legacy system to keep all those things up. So MediQuant started out, I think our flagship product really is DataArc, which is used for both inpatient, outpatient systems. Our focus is our customers and making sure that not only do we service them from the technology perspective, but the compliance perspective as well. So we recognize as part of the active archive that we are part of the legal medical record. And so we work to make sure that our customers include the data that's sitting in our system, because as you guys know, data is super important. The value of data has increased over the last several years, so has the size of data. So we're, as a company, constantly looking to improve how we store, how we support our customers in the market.
Very good. All right. First question here, and there's a lot here. And Kel, I'm going to throw you under the bus and make you help us understand some of this stuff. Let's start with the baseline information and definitions. We're all on the same page. What does the 21st Century Cures Act require that health systems provide to patients upon request? How must that information be provided, and in what time frame? What constitutes the designated record set, and what are the consequences of non-compliance? So I know you can't give us everything. You mentioned that things are over 1,000 pages to go through in terms of the content, but maybe just hit the highlights here.
Okay, so let's start with the first bullet you've got on the list. 21st Century Cures Act really is an extension or an added act to support the original HIPAA compliance. So HIPAA focused more on paper, it focused on the medical records, patient access at that point too, patient rights. 21st Century Cures Act then turns us and it starts looking at it a little bit different, looking at the medical record different. One, it includes the electronic version of data. The patient becomes the owner of the medical record versus the provider that was originally the owner of the record. The patient virtually owns it now. It has an information blocking component to it, so there are very few exceptions where providers cannot give over a medical record. It includes something called USCDI, which is a designated focus on clinical. It's a US clinical content list of things that need to be included and released to patients. We are currently looking at version 3 right now. Version 4 draft will be out in April, and then the final will be out for version 4 of this October next year. It also includes something called the designated record set. So designated record set is not just focused on clinical. Designated record set expands USCDI, which is focused on clinical, to include financial information, claims, anything that a patient might need to have in their overall record that might have PHI is included in the designated record set. So that's probably going to continue to expand. So some messaging, things that you normally wouldn't just include in your legal medical record initially are now in this designated record set. The information blocking component that I mentioned earlier, it also includes not just hospitals, but individual providers, HIEs, and payers. So it broadens out what they call actors in the Cures Act. And then another component that will come later, patient access, their own access to records. So though you may have access right now, let's say to your own medical record, the main HIS system, this will include a broader view of getting access to records on their own. It gives them more autonomy to pull their own records out of the system. And then you have kind of requirements around that. There's a lot of vagueness, I will tell you, in that 1,000 pages of things that is requiring groups, like Audrey and Tony to kind of get together, talk to legal, talk to compliance, and some of it is doing some analysis and evaluation of what those mean. Second bullet, how must that information be provided and in what time frame? So if you're storing, the law actually has a kind of a little clip in there, a little bullet in there that in the manner that the patient requests, but if it's available in that format. So if a patient says, I want all my lab results, I want the discrete values of that, then you provide it that way. If it's something that's stored like in a document and they say, I want you to break it all apart, that's not really a feasible thing to do right now. So it makes it, you have some leeway on how you're providing that record to a patient. Time frame, it varies depending on what kind of record it is, the access, who actually created the record. So if I go to an organization that was not the originator of my medical record, they may not provide it. There's an exception that they may send me back to the originating organization. So there's a lot of little details in there. But one thing that's very clear, they've got about 30 days. They only have to put in a request. They don't hear something, they can put in a second request, but they've made it very easy for patients to file a complaint against a provider. So about 77% of the complaints right now are against individual providers for not handing over that legal medical record. I think we talked a little bit about what constitutes the designated record set already. That is anything that is related to the patient record, including the financial, the claims information, anything that relates to a treatment or denial of treatment. All of that content is something that can be pulled into the designated record set. The last part of the Cures Act, or kind of a technology perspective, is being able to send things through something called FHIR. So being able to send those transactions back and forth, the designated record set will be one of those things that they're gonna need to be able to send out. And then what are the consequences of noncompliance? So some of those noncompliance, obviously the fines fall under HIPAA. They've gotten very good at looking for things that denials. And so the fines vary. They seem to be a bit arbitrary depending on the severity of the denial. So if a patient's requested, for example, one I saw, they've requested information. It's kind of different from their dentist. Yes, dentists are included as an actor, but they continually ignored the request for a couple months. That the dentist was fined about $100,000 because the dentist also ignored the letter from ONC about not providing the record. So there's some leeway in there. There's not a definite, but it does say for inpatients up to $1 million fine per instance. So you've got to get really good at documenting why you did not provide a record and don't ignore any requests. And you've got to consistently document. So you can't have, if you're going to treat all patients the same way, if you're going to say, we're not going to provide psychotherapy notes to patients because of, we feel that it might be a life or physical threat to their safety, then you have to be consistent with that. You can't give it to one patient, not another, in other words. So consistency is important. And I will turn it back to you, Anthony.
A lot of good stuff there, Kel. Appreciate that. Tony, let's stick with this sort of question here. In addition to anything Kel said, is there anything that sort of that you're thinking about a lot in terms of these requirements, or anything you want to add on or clarify about what you see as being required and being important right now?
Yeah, no, I obviously that's a great commentary by Kel. I think it's in terms of what we see is obviously patients want to see as much information as they need to, and we want to provide it in all circumstances. And I think the question is to decide, as with the way I look at it, coming from the outside, is relatively simple. Great, this legislation is great from a patient perspective, and I don't think there's any reason for providers or for provider systems not to provide it. But from my perspective, is I start with, why would we not provide a particular piece of information, whether a designated set or more? Why would we not do it? Yes, to the point earlier, there may be situations where that may actually be detrimental to the patient. They read those notes and it's worse for them, absolutely. But those would be the exceptions, not the rules. So we provide the rules. So that's one thing now. The trick is, though, the information we do provide, hopefully in the most convenient and self-service 24/7 way possible, not by CD-ROMs, that information, or worse, by fax. That's probably, healthcare is probably the only place that's still used, maybe, as an industry. But also in a way, in a format that is consumable. If I look at and try to read those notes, the visit summary notes, for example, is that something that would help me manage my health? Because I think that's what the ultimate desire is, to help patients manage their health, not just manage healthcare, which is interaction with us and what we provide, but them manage health. And that's why that information is accurate, or is important to be available. Can they manage? Can they understand it? In my past, I'm knock on wood, I didn't have major problems as a patient so far. But some of the notes that I read, there might have been might as well been in Chinese, because probably in 2 pages I understood like 6 words, and then fortunately they said, it's probably not too bad, don't worry about it. So okay, then I had to wait for the follow up with the doctor, which basically gave me that one sentence that clarified that it was okay. Yes, you're getting older and that sort of thing, but nothing to worry about. Which, by the way, those notes could have had in the very top of the summary for the patients. You're going to be kind of okay, and the rest is for whatever reason. So we need to be, as the digital officer or the digital experience officer viewpoint, and how do we make all that information usable for patients in ways that they can understand and they can act upon. And then from there is, what is it that we can provide further? Okay, there's maybe follow-ups and that sort of thing that we need to lead to the next steps.
Yeah, it's a good point that if we see the direction things are going in and we can go beyond the requirements, why not go beyond in terms of a longer term strategy? Audrey, in terms of what you're seeing from the policy point of view, the specifics of what's required and when, anything that sort of you want to touch on for your colleagues who are going to listen to this and who are listening to this, that has caught your eye, or things that really you want to focus in on?
Yeah, 2 thoughts. I think Kel did a great job summarizing it, and some of the detail I learned listening to her. But fundamentally, number one, it's been just acknowledging it's been transformative. Right now, it's almost like Monday morning quarterbacking, right after this has all happened. But what has happened is a greater transparency, these quicker release times, not withholding information. Of course, there are risks that have been recognized. One of those risks being information being released to a patient before a provider has had a chance to engage with the patient. That is a classic concern you hear from clinicians, and that needs to be managed. A second risk, we hold all this PHI, we protect it, we understand our obligation for that, and I think it's reasonable for healthcare providers to ponder what now happens when that is released to the patient. And let's say the patient is not as careful with their own information, or health IT developers or other organizations who now are using this information are not as careful, are not under the same HIPAA obligations as we are as healthcare developers. Now, is there any accountability that points back to us? We hope not, given the way this is rolling out, but the origins of the data are still with you and your organization. How would you ever prove that that data was released through one mechanism versus, nefariously released through your organization? So there's some questions about the data, its origins, sort of security, and the way that data is used. A second thought, Anthony, is about this broad term of EHI, or electronic health information, which Kel commented on. I mean, it is far-reaching, right? And you take a look at your portfolio of systems, and yes, we as many organizations are now, let's say, EHR-centric. We're primarily EHR-centric, but you still have a bunch of other things in your environment. That is all EHI, and you're now in a position to have to work with multiple vendors to develop a strategy for how are we electronically accessing and releasing this information. So, for example, in our organization, we have 142 vendors that we need to interact with. And as a first step, as we were preparing for this, we sent out a survey to the 142 vendors. Of those 142 vendors, only 20 even responded to the survey, right? So 122 blew us off, right? And of the 20 that responded, essentially it was, yeah, we're in various steps of development, we'll let you know, right? There's only a couple that were definitive in how they're going to help us as their clients comply with the spirit, right? With the 21st Century Cures Act. Of course, the electronic health record systems are on top of this, right? This is not about them. This is everything else that is not a certified EHR. So therefore, those vendors are not held to the standard, yet we as health systems are held to the standard to be able to release all the EHI. So a little bit of an inconsistency, if you will, about what standard we're being held to versus the standards of the vendors and the organizations that support us. So we get historical stuff, right? And this is where I realize MediQuant and other archiving solutions play a huge role. We're ultimately going to take data of our historical systems, put them into archives, those archives need to be accessible through FHIR, right? Because this is going to be part of our strategy for how we will deliver upon at least that part of the data. And then there's other data which we don't. I want to recognize we don't really have a strategy for a lot of this data. This is why we're doing these surveys and trying to get information from these vendors.
Yeah, so these are the vendors. They're, you know, not the EHR, right? You got your EHR. You have companies like MediQuant that can help you move data around and archive data and things. You sent a survey to 140 of your other vendors that have some data and said, hey, how are you going to help me with this? And they were like, they passed the letter around the office until nobody wanted to deal with it. Because they're thinking, they're thinking, well, that's kind of your problem, right? Is it? Yeah.
Very much so. Some even said, what is the 21st Century Cures Act?
Yeah, and I think that's.
You said call Kel. You told him to call Kel. Go ahead, Kel.
I was going to say, you know, and that's, we took a very, so just how we looked at this, Audrey, you know, and I think we've touched on it a little bit, but when this first came out, and, you know, the 21st Century Cures Act, the piece that we thought would affect us was in March of 2019. We started immediately, took it to development and said, listen, it specifically says certified, you know, health information technology companies. And though archives don't require the certification, we looked at this and said, this applies to us because we have the designated record set. We have USCDI. We're part of the legal medical record. Even though we were not, you know, archives aren't required to be certified through ONC like an EHR is, we made the decision that we absolutely are going to be required to do this. And we are going to, if it never comes out and no one says, yes, you have to do it, we decided we were going to make the commitment to our customers that, of course, we're going to support this because you're going to have to pull this data out of the archive to make up that whole record. So at that point, we took a boot camp. 3 of us went through a boot camp with Sequoia Project, who's working very closely with ONC right now. We formed our health regulatory committee. We started looking at USCDI-1, and it's just grown from there. We are, you know, successfully sending FHIR transactions with our government project. So we're ahead of the game right there when it comes to the FHIR piece of it. And so we've from that point been working consistently to make sure that we could support this. And I think that is probably a bit of a differentiator when you're talking about the 142 vendors that you have out there. They're not necessarily understanding whether or not, or looking into whether or not they're going to need to be part of your overall piece of it and support you, even if they don't have to be certified. They're still specifically going to be included in that group. And as a, you know, under BAA agreement, absolutely, we are an extension of you. That's how we kind of look at this.
So we thank MediQuant, and generally, I'd say MediQuant and other archival vendors have very much understood their role in this process, right? And you know, you very nicely described how you guys went through it. I'm sure other archival solution vendors, similar process, right? They understand that they will be the repository of information that is part of this record set that ultimately needs to be accessed through APIs, needs to be able to disclose, right? So you guys are a huge solution to part of the puzzle. And then I think just recognizing not everybody had such a forward-thinking, you know, so forward-thinking about this, right? Again, archival solution vendors generally, yes. But this is the problem we face as a health system, right? That we have a couple partners that are on it, that we can count on, and then everybody else, and I can't blame them because they technically are not obligated to do so, right? But somehow we have this obligation because all that data is part of the designated record set.
Right.
Tony, Audrey has brought up the question, and I've heard this before, of a concern on the part of health systems about what their patients do with the data they're given. You're sort of wanting to advise them about some of the issues of giving data to some of these third-party apps that may be in an app store, and maybe, you know, based out of who knows where. And there's some concern, right, Audrey, about wanting to put them in a good position, maybe even some basic education about what they may or may not want to do with that data. Do you have any thoughts around that?
Yeah, no, absolutely. Before that, and somewhat related to it, I wanted to add a comment on whether patients should see or ought to see their medical rate data, let's say lab results or an appointment results before the providers have a chance to talk to them. I know that I've heard that concern, and I've heard it from providers and sometimes even from patients. And the way I look at it is very simple. Let's put that power to decide back in the hands of the patient or the consumer. Yes, there are patients who prefer to talk to hear especially bad news from their provider, their clinician. Others, probably the certain younger generations, find that the wrong avenue, and they simply would prefer to see it in an app. I think that there is a way to map both, not just rely on physicians saying, no, this is us to deal with it. We can provide that ability for patients to decide how they want to get the information and whether they need to wait for the provider to reach out, whatever. Now, the moment you say, yeah, I'll reach out for the provider, you have to wait for 4 days. That's an indication it's probably bad news, because otherwise you would have. Anyway, so that's aside. Now, on your question about yes, the way I look at it, and as maybe my personal view is, this is about patients' data, and they're entitled to it. They absolutely can have access to it. They can grab it, and they can do all sorts of things with it. I think there is some education that we need to do. It's not necessarily any of us as providers. But some education on what this data can be, how important it is, and how can it be misused. It's quite often for folks to share incredible level of details, medical details on even social media. I had one of these, blah, 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 and like and by the way, that's their right. But I
call that oversharing. It's oversharing.
Oversharing. It's their right, definitely. But also it can be manipulated, can be misused, can be in the wrong hands, used as a unfair bias against the person. Who knows who reads it and what they do with it even years later. So I think some level of education, absolutely, we need to do when we allow them to take it, to download it, to forward it outside. But I think it's, at the end of the day, as I said, it's their data, and they with the right tools and the right education, they should be able to do whatever it is in their hands. Is again, is their data.
Right. So education.
I wouldn't want to to post my social security number and my credit card details, including the special code, on my website, but if I'm crazy enough to do it, I can do it. Now, very likely the credit card company will just terminate my account, because that's but in the end, that's something that I could do.
All right, very good. Audrius, we're going to start with you. Now we talked about what's required, what has to be done. We all said, yeah, it's great. It's the patients. They should have their data. Maybe there's some caveats in there with certain sensitive data, psychiatric data, where you want to be careful. And we might want to provide them with some education so they don't just go putting it on any app, but that's up to them. Okay, so we've covered that. What are the challenges of doing it? Now, you mentioned about the hundreds of vendors, and some not writing you back and filling out your questionnaire, and happily doing so. What are the technical challenges now of getting all this stuff together?
Yeah, well, it's getting all this stuff together, right? And you start with. So I'd say it's a journey, right? What you recognize, it's an evolution, and you're going to start with 80-20 rule, very much applying here. You're going to start targeting those platforms that contain the vast majority of your data, which in our case will be our electronic health record systems. Thankfully, our EHR vendors are generally well on top of this and ready to support us through that, right? So there's various mechanisms through the EHRs where you can expose that data to your patients, whether it's portals or other electronic means. The next thing I would look at is sort of now we're into the archival platforms, where there's a vast amount of data being maintained there too, right? That's the next thing you're gonna tackle. We have started that process, are working through that process with our clinical data. We've already done it with our revenue cycle data. So that'll be the next thing you tackle. And then I guess comes the other 140 out of the 142, right? Because then it's just a matter of one by one, right? You got to step through it. And just like security, right? We talk about a risk-based security model. I'm very much sort of this attitude of, you won't be able to do it all at once. That's sort of idealistic and unrealistic. So you got to do it based on sort of risk, right? Which are the largest data sets? Which ones do you want to incorporate? And I realize we're not perfect at this point, but we are working hard to try to meet the spirit of this thing and show progress towards achieving this ultimate goal, which I believe is a good goal. Everybody's commented on that, right? We want to expose this data, make the data available to the patients and to the apps of their choosings. The point of the 21st Century Cures Act was to stimulate innovation. I mean, that was the intent of this, and to deal with this interoperability question. We're going there, but it's taking a while. The dates, we can argue whether the dates were too aggressive or not aggressive enough. They are what they are. They're pushing us now in a certain direction, maybe not as fast as others would like to see us move, but we're going there, right? So it is just about a systematic, consistent approach to achieving this goal and objective.
Very good. Tony, your thoughts?
No, absolutely. I think you're right. Depending on each individual case, where that data is, it's sometimes for certain systems, maybe it's all in EHR, and that's relatively simple unless the EHR has limitations on how easy it is for people to get data out. Sometimes it's probably maybe more than one EHR, or maybe more than one system. You have an EHR and then you have some other things, other systems, maybe for revenue cycle. So I totally agree with Audrey. It is a journey. So we kind of know, and probably that limit is going to be expanded, what we will eventually want to share, as I said, as much as possible, unless there's a very good reason not to. But it's a journey, and if it's something that you can expose tomorrow, and then something that can come in 2 weeks' time, and so on and so forth, gradually, as much as fast as we can. But we all should have started. It could have started a lot earlier, if we peered into the future. But we are where we are. But definitely so now.
Very good, Kel. Anything you want to jump in on? I've got this. I put up the next question, which goes to some of the specific things that we could touch on. So we'll go back around with that. But Kel, let me get your thoughts.
Actually, I think probably one of the biggest things for us from an archive perspective is going to be what's on your next slide, and it has to do with patient matching, unique identifiers, those kinds of things. Anytime you've got a patient accessing their own record, you have a bigger HIPAA concern than you had before. If a provider gets a list of patients, they can say, oh, well, this guy, the third one down, is the guy I'm actually looking for. If you've got duplicate medical records or MPIs, names, but you can't give a list to a patient, right? A patient has to only ever see their own record. And so that is certainly going to be a challenge, especially, and it's going to differ by organization. That's certainly one thing that we recognize, because our customers made different decisions on how they wanted to archive, whether they merged databases, whether they did a cleanup of their MPI. Mergers and acquisitions actually play into that also, because some of them gave new numbers to those that they acquired. Some of them didn't. They just said, put it in the archive and the provider can look at it. Some of those decisions were prior to all of this stuff coming out with the Cures Act here. And so now it's going back and looking at each of those individuals and say, okay, we're going to have to develop a strategy based on the decisions you made. So that, I think, it's not an insurmountable challenge, but it is a challenge to look at each of our customers as individual. Not one of them made the same decision on how they did stuff. So that's probably, I would say, is one of our biggest focus, especially as we talk about patient access.
Yeah, you're right. I think, let me interject a little bit. I think you make a great point about, and us for example, developing digital capabilities before, or sorry, after the EHR was implemented, and after, obviously we had patients. The question now is, how do you get them access, and in a way that you're absolutely sure this is the right Michael Smith or John Smith or whatever it is, not 5 others in the area. And sometimes that reduces the simplicity of the access as you validate the identity, and it has to be with something that they know. Unfortunately, with the internet, a lot of people know about you almost everything. So it has to be something that you have, like access to an email or a cell phone that, or a phone that you had provided before, or whatever else mechanism that we can. So I think that's an important one, that sometimes it makes things a little bit more difficult, and people say, "Oh, I can't get into my whatever." But because we need to make sure absolutely that you're and somewhere on the internet trying to get in, you are the owner, full owner of that data and that record.
Yeah.
These concerns clearly existed before the 21st Century Cures Act, right? Operationally within healthcare systems, we talk about duplicate medical records, collapsing them, making sure information for a patient is not spread across multiple records. When we become aware of them, let's merge all these things together. These things, definitely this is a concern, right? To have the integrity of the information associated with a patient and their record and their health and their healthcare delivery. I think Kel's point is so well made that this is like on steroids now, right? Because now you're sort of bringing this question, right, or this concern out of this protected group of healthcare providers that all have been through HIPAA training, all understand their obligations. Now you're bringing it to a much broader mass audience by exposing to patients, and then you better make sure you have it right. So, Kel, it's a phenomenal point. Like, we really got to get good with this matching.
Well, yeah, not everybody would, honestly, if I got a list of patients, I went to my record and there was somebody else's record, not everybody's going to call and say, "Listen, guys, you got the wrong record on my record," and not open it, right? I'm a nurse, so I'm like, that's not my business. Mm-hmm. Most people are going to look at the record. They're going to be like, "Oh, I know this guy." So just that thought of doing something like that, or a patient doing that, just almost makes you sick. Like, oh my gosh, we got to get this right. So yeah, it's a big deal for sure.
Tony, where are you on the idea of an organization-wide unique identifier that goes beyond the EHR and touches the other systems we talked about? Is that something you have or should want to work towards, or is that just not how you're looking at it?
Well, I think it's something that one would want, and this is the case for all the industries, not just the patient. And if you're in a different industry, you want to have one record and one identifier for a customer of whatever kind.
Right.
And so that definitely would help. But just as like everywhere else, getting there, the growth was somewhat organic, and maybe you had acquisitions, and maybe the organization didn't align very well, and you had different systems springing up everywhere, and where they didn't look at which system should be the true system of record. When you go into a place and you say, "Is this the system of record for this piece of data, or is that system of record?" And if you get the answer yes, then you have a problem. And you talk about system of record is not supposed to be a plural, systems of record,
right.
Yeah, for the same piece of information. But sometimes it's unavoidable, as I said, especially, in certain circumstances. And as the long-term goal would be to have those. And by the way, it's not just about consumers. It could be about even physicians, or about clearly employees. But that's easier to fix, by the way, or whatever it is. Even insurance plans that the organization takes, is all the organizations in the system that deal with insurance plans, they actually have the same system of record for that. And so it's a great goal to have eventually. In the then probably would be the next big migration kind of a focus. In the short term, you need to probably have to be practical. The goal being not necessarily to have one, but to have the ability to traverse the organization in your systems in a way that wherever that information is about that patient, you can recognize it. And then that could be simply by, having translators between systems. So when you do want to say, hey, I'm looking at the HR here, but there's all that system over there that I don't know, but then the system know how to find that record over there for some sort of translation of identifiers, that may be something that you may want to do.
Audrius, what are your thoughts there?
Yeah, I keep thinking about these efforts to convince our legislatures, our government about a national patient identifier. And I don't understand all of the political issues and legislative issues behind it. I'm a little bit stymied that we as a nation are not moving in that direction. I have a colleague who is originally from the UK. And when you hear about, right, in the UK, everybody's got an NHS number. They know it by memory, right? Just like you could rattle off your social security number. At least those of us, who use that as a primary identifier when we were in college, right? Posting test results, right? You look up your test result by your social security number or your exam result. So, I mean, this is fundamentally the problem. Now, this would create a platform upon which things could be unified. You still would have that internal challenge of having to find all the instances of that patient's records within your platforms and then associate them all with that record, right? So you still have this challenge of duplicate medical records, of somebody not being careful when a patient came in to see whether that patient existed or had a record at your institution. So those operational challenges, again, they existed before, they continue to exist. We need to continue to work towards it. But this idea of a national ID would assist in this in this capacity, and I feel we're a little bit handcuffed in this country because of that. So it would have been great if, together with the 21st Century Cures Act, this idea of a national identifier would have been sort of parallel legislation, but it wasn't. And I realize there are still substantial initiatives in place, some of them being led by Chime, some of them being led by others, to continue to sort of raise awareness to this topic.
That's a very good point. I was going to say,
Kel.
very good point, Audrius. I mean, years ago, I would have thought, gosh, a national identifier, the Big Brother thing, I think that was the holdup. Today, it's obvious that I agree with you. We've got to get something that's like that. That's a national identifier. I think some of the holdup is who would own putting it together. Because we have so much competition right now with our vendors and different things so they would have to delegate or create an organization within the government to generate that kind of stuff. But I agree with you. That would be the simplest thing for us to do, is to get a national identifier, and then it would take it. This would not be an issue. We would just get, everybody would get one, and they would have to work through all the things they've learned about the social security number on, because there's been a lot of fraud with social security number. That's why we don't actually do it. But having a system. I was on a call for Canada yesterday, actually, that was really interesting. They were talking about everyone there is getting a DUN number for their region, and then a number after it. That's how they're getting their numbers. And I thought, gosh, that's interesting, because all hospitals have a DUN number. Really, everybody gets one of these things. And anyway, I think that there's going to be more discussion on that over the next few years, just because I don't know how else they're going to manage some of this technology without doing something like that.
All right, I want to get to some audience questions here. So let's jump right in. Kel, I think I'll put this one to you. Interoperability seems to be hinged on the sharing of patient information. Can you give a high-level understanding on the difference between HL7 and FHIR?
So HL7 really is a standard. It's not just a national standard, but it's kind of an international standard of interfacing messages. So it's very strict, certain message types, and you build it out. FHIR is, I think, gives a little more flexibility, but it's still a set of standards. So you're not building the same messages. You can have like an outside or a third party. It's almost like a middle layer type thing that will translate between one message that you have, or you're building your own specs for FHIR and someone else's specs for FHIR to be able to send those messages. I think it's more flexible. It is an HL7 basically type thing. It's just HL7 on steroids is the way I keep describing what it is. So I think there's more flexibility to it, and there's absolutely more potential for it for people to send bigger messages, different types of messages, because HL7 by itself is somewhat restricted text, whether it's a TXT, whether it's a A1 has this, you know, an A8 is this, and not that we're not going to get away from some of those components, but I think it's going to expand our ability to be interoperable.
You know, if I add a final comment. Oh, sorry, Tony, go ahead.
No, you go ahead.
I was going to say, they are technically both under the HL7 umbrella. One is we refer to as typically version 2.x, which is the older message-based integration. Okay, I'll call it old message-based integration. And then, of course, the more contemporary approach using APIs, specifically Fire. One differentiating characteristic that I always think about is that HL7 2.x, you're broadcasting out a bunch of stuff all the time, and then the receiving system can choose to listen and save it and store it or not, right? So it's a message-based integration. And with Fire and APIs, we get rid of this chattiness, and if you want something, you specifically ask for that, right? And you make a request, and you get an answer to your request. So sort of a fundamental architectural change.
Flexibility.
Again, flexibility. Yeah,
absolutely.
Yeah, no, I agree. And I was going to say, simplistically, HL7 is like the old EDI, and we used to use in the financial industry, and then the Fire, at least the current or the upcoming version, is more like web services. So I think standards are important, but I think also, outside this area or this industry, we've been using APIs that are not standardized very, very successfully for a very long time. As long as they're implemented well, they're well documented, the semantics is clear. So I would take a well-defined and implemented API of any sort with modern technologies, whatever it is, over a standard that has more limitations. And because vendors said, we need to stay within the standard, so we need to wait for the standards body to spend another 7 years debating how that format has to be. So my 2 cents.
Good. Those are good sense. We appreciate that. All right. Next question. How should a provider deal with a personal health record supplier who wants EHR access on behalf of patients? The supplier is not bound by HIPAA and can only attest to properly identifying a patient and giving them appropriate data. Audrius, I'm going to put you on the spot for that one. What are your thoughts, sir?
It's the essence of the problem, right, that we were talking about earlier. So first of all, right, the request needs to come from the patient, not from the supplier, right? So organizations have processes which patients can ask for this, and then they identify this particular PHR or this particular supplier, right? So the relationship is a little bit different, right? It's not about the supplier asking for the data, it's about the patient asking for their data. And of course, then you make sure you have the right authentication, right? The right controls in place to make sure you're only providing that patient's data and you're only authorized to provide that patient's data. But then what happens after that, right? It's a little bit out of your hands, right? And we reference this, right, about educating the consumer, making sure they know and they are an educated consumer about whom they're sharing their data with and what that company is obligated to do, or more specifically, not to do with their data. So I think this is the part, Anthony, you referred to, right? This is the part of this regulation that usually gets a little bit of a reaction from people. Like, we take all this care to protect this stuff. Are we, and the way Tony put it, right? You can post anything you want, right? This is your choice, but just to make sure our patients are educated consumers and understand what they're doing. If they then choose to do so, that's on them, right? But we want to make sure our patients understand what they're doing.
But for Tony, for this question, it's a simple no. It sounds like this is the PHR supplier who wants EHR access on behalf of patients.
But to Audrey's point is, has the patient granted that permission?
It doesn't sound like it.
If not, no. So on what basis? And unless it's some subpoena thing, I would probably say no. Obviously, I'm not a lawyer, but now with it, where I think the more cases, I think, is where the patient indeed wants to provide that information. And we talked about it before. I think there are technologies on the horizon where that process can be a lot more secure and maybe with encrypted, maybe with blockchain, in ways that the consumer can go and say, this blob, okay, this vendor can have it for this purpose. There's a contract around it and there's an expiration around it,
Yep.
which would make it a lot easier.
I think the biggest question is it for the continuation of care for the patient? I mean, they sign a statement right now that says the record can be shared with the payer. It can be shared, you know, with other providers because it's a continuation of their care and they're part of the care team. If this group is not part of the care team, then I would say they have to absolutely sign a release. The patient needs to sign the release for it to go specifically. I agree with Tony. I can't imagine any other legal way around that. I think that the rules are very specific about who gets access to it. And as a patient, I know you guys have all been patients too, we signed the release, but the release specifically, you know, with your records, it's to people that are going to be part of your care team. So if they're not defined and designated as part of the care team for that patient, then I'm with you guys. Absolutely, I wouldn't send it.
All right, I'm going to pose a final question. We're just about out of time. And I'll phrase it this way. It seems like, you know, we can do these things. We want to do these things. But to me, the rub is going to come in on the timing. And, you know, things are still being worked on. Cal, I don't know what some of the deadlines are, but things are still being worked on. Audrey has talked about still working through this process and having to do it in a risk-based way, which makes sense, which means you can't do them all at once. Let's prioritize and work the list. What about when we get into situations where requests come in, we're under the requirements of the guidelines and the law, and requests come in, we want to respond, and there's a timing issue of, well, that was the 82nd vendor that we need some data from, and we didn't get to that one yet, and I have 30 days to reply, and to the patient, and I just they ignored another letter from me or whatever so the question of the timing, the penalties, and getting this stuff done, do we see that as an issue on a case-by-case basis where perhaps in certain scenarios, we're not ready to reply in the required time frame, and what's your best advice to dealing with that? Tony, I'm going to start with you.
I think we have a model here, which is when the European Union introduced GDPR. One of the requirements was the ability for a consumer, a customer, to get any information, not just medical, any information from a vendor. And I think a lot of folks were not necessarily prepared for all of that, though, despite the fact that the law had been discussed. And so everybody did was, okay, we're working on the system where, yeah, you can go in and get it yourself in a way that is very easy, and it is as complete. But in the meantime, we're going to do our best to get as much as we can, as fast as we can, even if sometimes that means some sort of manual approach. I don't see that in any other option. And frankly, the painful of that manual approach for the company, it's probably is going to drive a huge incentive to do the self-service.
Audrey, your thoughts about the timing of this, responding to requests in the required time when you're not sort of fully finished, getting ready?
Your Honor, I refuse to answer that question with fears that I may incriminate myself. No, okay. So it's a real problem. I love Tony's answer, because that is the way you're going to approach this, right? I think maybe it's naive, but my optimistic hope is that you engage with the person posing the request, and part of the rule suggests that it needs to be reasonable in how you can present that. Mm-hmm. If we can't do this through automated fashions as Tony has described, there's always a way to extract the data and bring it forth. Now, the question of how usable it is maybe comes into play. But there is a way to do this if someone is really motivated. So you're going to do your best on that 82nd vendor. Right. I think the big concern some of us have is, look, if these are legitimate patients with legitimate needs, happy to work with it. I think there's also a little bit of concern that I'm not sure what the data shows, that there are some organizations or individuals that might be purposely going after health systems, right, and trying to profit from this. From going through a little exercise of asking things that may not be reasonable and may not be within that initial scope.
Mm-hmm. Yep. All right. We'll see what happens with that. Kel, we'll give you the last word. Your best piece of advice.
Document, document, document. I think that you lay out your plan, you stick to your plan, and when you have an exception like you guys are talking about where you have to pull it manually because the data is either stored weird or you don't have access to it immediately and it's going to be a delayed, you document the reason for that. And when you come under fire and get an audit, you've got everything lined out and they can't say that you didn't give every reasonable, probably above reasonable effort to accommodate that request.
All right, that's some great advice there, and I cannot believe we're out of time already. Regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording is ready for viewing. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team. You can go to our website to register for upcoming panels. With that, I want to thank our tremendous panel, Tony Ambrosi, Audrius Polakaitis, and Kel Poltz, and I want to thank MediQuant for sponsoring and making this valuable educational session possible, and I want to thank you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you, guys. Thank you.
Thank you.
Audrius and Tony, Anthony. Have a good day.
Thank you.
Thank you.
Bye-bye.
Bye-bye.